Okay, this is going to be a small lecture on the genetics of movement disorders. Um, and so this is with regards to Parkinson's disease, which is the case. The most common cause of Parkinson's disease is multifactorial, which means, if you remember from the multifactorial lecture, there's genetics, there's environment, there's a combination of both. It's complex, and we don't really understand it very well. There's genetic factors, environmental factors. We don't know what the environmental factors are. They're starting to understand some of the genes, but because they're just starting to, in 20 years of your practice, you might realize that this is completely wrong, but at this point, consider it multifactorial. Approximately 15% of cases of Parkinson's are caused by an autosomal recessive single gene. I'm not listing these genes because they change often and you don't need to memorize them. Individuals who are carriers, not affected, but carriers of a GBA gene, which causes Gaucher disease, if you have two non-functional copies, are at increased risk of developing Parkinson's disease. And we will talk about Gaucher disease at another time, but that's going to be presented more next year. However, if you're a carrier, not affected, one non-functional copy, you are at increased risk of developing Parkinson's or Parkinson-like disease. So that's really what I have to say about Parkinson's disease, but I'm going to spend the rest of the time talking about other movement disorders. And one is Charcot-Marie-Tooth. And Charcot-Marie-Tooth, or CMT, is a hereditary neuropathy characterized by chronic motor, sensory, and polyneuropathy. And there's distal muscle weakness and atrophy with this really high arch to the foot and depressed deep tendon reflexes. It's CMT type 1 is the most common. About 70 to 80% of Charcot-Marie-Tooth are type 1 or CMT1. It's inherited in autosomal dominant fashion, which means you only need one copy of this gene non-functional to have an issue. Affected individuals usually start showing symptoms anywhere between age 5 and 25, although starting to show symptoms and actually being diagnosed is often quite a different age. Fewer than 5% of these patients become wheelchair bound. It's caused by a mutation of the PMP22 gene that's involved in actually wrapping around myelin so that the nerve conduction is, efficient. It's kind of like, when you have an electrical cord, you need to have that plastic around it. The most common change is a duplication in this gene that causes it to non-function correctly. Sometimes there's a deletion, but in most cases, the two copies, there's like a crossover here, and we have a duplication. The next movement disorder I want to talk about is a very difficult one called Huntington's chorea. And it's a progressive disorder of motor, cognitive, and psychiatric disturbances. The mean age of onset is between 35 and 44, and it's inherited in autosomal dominant. In this photograph here, here's a young man playing football in high school, and here he is at 30 after developing severe symptoms to the point that he's ataxic, he's in a wheelchair. It's caused by an expansion of CAG repeats in the HTT gene. So triple repeat disorders, we've gone over a couple of them, and we'll go over more as we move forward. There's an expansion of repeats. Why there's repeats there in the first place, I'm not 100% sure. Sometimes this expansion is in a coding region, and sometimes it's in a non-coding region. Sometimes it's outside the gene on the 5' end or the 3' end. But as it gets larger and larger, which is known as anticipation, the symptoms get worse and worse. So it gets worse from one generation to the other. And we talked about this when we talked about myotonic dystrophy, and this is another example. We just had the same slide, but here we have Huntington's chorea. And Huntington's chorea is an expansion of the CAG repeat in a coding axon. And we talked about myotonic dystrophy. Most, there's dominance, some are recessive, some are X-linked, Fragile X. We're going to talk about Fragile X next year. This is a really important one. This is just a little aside. When we do whole exome sequencing, we don't pick these up in general, except for, and even with Huntington's, it's hard to pick up. You actually, when we move to whole genome sequencing, which will probably be what we'll commonly do in the next 5 to 10 years, then we'll actually pick all these up seamlessly, but you actually have to test for these at this point. Huntington's disease, as I said, is an increased number of CAG repeats in a coding axon, and CAG codes for the amino acid glutamine. So it results in a really long chain of glutamine, and this affects the protein, the HTT protein, from folding correctly. That ends up causing neurologic issues and resulting in Huntington's chorea. The greater the number of CAG repeats, the earlier the onset of Huntington. Normal individuals have between about 25 CAG repeats. When an individual has 27 to 39, they don't develop Huntington. However, during meiosis, it can, it's actually, remains stable during meiosis, but can expand during spermatogenesis. During meiosis of spermatogenesis, it can expand. Individuals between 40 and 60 CAG repeats begin with symptoms between 35 and 60. When you have 70 to 90 repeats, you can start showing symptoms in your 20s. And greater than 90, you can start showing symptoms in childhood. The larger the number of repeats, the more unstable it is, and the greater the expansion. And the CAG increases during spermatogenesis. So the increased size occurs during spermatogenesis. And let me just show you, here's a slide here with the whole concept of anticipation. I know we've talked about anticipation, again, when we were talking about myotonic dystrophy. But here this mother developed Huntington's at 41 years of age, and she has 2 alleles, one with 48 and one with 30, and the 30 is normal. So the 48, she has a number of children, and this individual developed Huntington's at 43, and he has a 47 and 31. This individual developed Huntington's at 40, a 47 and 30. So both of them got their mom's expanded allele, but in both cases, they actually went down a teeny bit, but not much, from 48 to 47. However, this individual who developed Huntington's at 43 with 47 repeats had a son who now went from 47 to 50 and developed symptoms of Huntington's at 33. And again, the 31 came from his mom. So this can get worse from generation to generation. And it gets worse during spermatogenesis. It usually stays relatively stable during oogenesis. So genetic testing of children for HD. The only acceptable reason to test a child under 18 for Huntington's chorea is if they're showing signs of the disease. So if they're having dementia, psychiatric issues, or movement disorders, you are not doing pre-symptomatic testing, you're doing symptomatic testing. Children cannot give consent. People have actually killed themselves. When we do actually genetic testing for Huntington's, it's usually with a genetic counselor as well as a psychologist. This is a horrible disorder that at this point right now, the day I'm giving this lecture, we don't have any treatment for. And so it's just that you'll know that bad things are going to happen. Sometimes women want to know they're at risk, but don't want to know, but they don't want to have an affected child. So we sometimes even do linkage analysis to make sure, for instance, if they got the allele from their mom or their dad, that they give the other parents copy of that chromosome to their offspring. They only, implant, they go through IVF and only implant babies that came from that, the other parent's chromosome. That way they don't need to know. And that concludes this presentation.